I apologize, I was muted. Hello, and thank you for joining us for today's virtual education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled The Role of Genetics in Cancer. Before we begin, if this is your first time joining us, CSC South Bay's mission is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by communities so that no one faces cancer alone. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join our community, please visit our website at cscsouthbay.org. Before I introduce today's speaker, we ask you to keep your microphone muted to eliminate any distracting background noise. Please feel free to enter your questions into the chat function found at the bottom of the Zoom window. And for those in person, we can get to your questions at the end of the lecture. Without further ado, I'll introduce our workshop speaker. Karen Lappen is a certified and licensed genetic counselor at the Memorial Care Todd Cancer Institute at Long Beach Medical Center, specializing in inherited cancer predisposition syndrome. She completed her Master of Science in Genetic Counseling at the University of Colorado. In her role as a genetic counselor, Karen has been able to provide her patients and their families with guidance about potential underlying causes of cancer and has helped them to use tools to make medical decisions along their cancer journey. Thank you so much, Karen, for being here with us today.
Thank you so much for having me. So as Rebecca introduced, my name is Karen. I'm one of the genetic counselors who works at Long Beach Memorial Medical Center. And again, if anybody has questions, feel free to jot them down, and I'm happy to take those questions afterwards, unless you have any clarifying questions, and then hopefully we can make sure that those all get clarified during the presentation. So today I'm just going to talk a little bit about the basics in terms of the role of genetics in cancer. And so what I'm going to talk about again is just cancer and genetics, giving you a little bit of the basic understanding of this. Talk about some of the types of genetic tests that are out there, because the market has really blossomed in terms of genetic testing. And sometimes it's a little bit complicated to figure out what type of testing people have actually had. So hopefully I can answer those questions. And then I'm going to talk a little bit about some of the myths of genetic testing and hopefully be able to clarify some of those questions that people may have regarding the genetic testing. So when thinking about cancer and genetics, we actually know that cancer is actually a genetic disease in terms of the fact that it's associated with changes, or what we call mutations, within genes that control the way our cells grow, function, divide, and differentiate. And a cancer has the ability, once it develops all of these mutations, it can start evading all of those checkpoint processes that we have in place to try and keep our cells under control. But the difference is that not all cancer is inherited, meaning most cancers are actually just completely random and sporadic. So if you look at the pie chart here, it shows that about 75 to 85% of cancers fall into what we call a sporadic category. What that means is that sometimes these cancers are due to just our normal aging process. As our cells are exposed to different things, and as they grow and are exposed to all of these different things, that can produce a lot of different mutations within our cells that can potentially help our cells grow into a cancer. Sometimes our lifestyle is associated with increased risks for cancers. Our body mass index can sometimes be associated with cancers. Female gynecologic history can sometimes be associated with cancers. And a lot of cancer is actually unknown. We actually have no idea what mechanisms are taking place inside of the body to allow those cells to start growing out of control and grow into a cancer. Now, if you look at the pie chart, there's also a blue category that we call familial cancers. These are when we see cancers in a cluster in a family. So maybe a group of siblings might all have lung cancer together. But if we think about their environment, maybe they were all exposed to a similar environment. They have smaller genetic components that may have led to them developing those similar cancers. However, it's not necessarily in that hereditary category. The hereditary category are when you actually have one predominant gene that is associated with an increased risk of developing a cancer. So to kind of talk about that in a little bit more detail and see where this all comes from, we have to trace that back to our cells in our body. So if you think back to the last time you may have taken a biology class, you might remember that our bodies are made up of these tiny microscopic structures called cells. Inside of our cells, we have structures called chromosomes. And those are structures that carry our genetic information in the form of a molecule called DNA. If I were going to stretch out a chromosome and look at it, lined up all along that chromosome are segments or pieces of information called genes. Each gene is like a recipe. It's a step-by-step instruction to make a protein in our body. And then all of the billions of proteins that we have within our bodies are working together and operating together. And that's really how our bodies can function, is with the help of these proteins. So if we kind of think a little bit about it and kind of switch it up with an analogy, if I think about a recipe book is kind of like our chromosomes. These are all of the instructions that I have for all of my different recipes. And if I turn to one page of that recipe book, that's like a gene. That's like a step-by-step instruction to, let's say, make cookies. And the end result that we get, or the cookies, are kind of like our proteins. So we are looking at this genetic information and comparing those recipes, looking at these different recipes to see if the protein or that final product that it's making is going to be the right kind of product that we need to be able to do its job within the body. So again, kind of thinking about cancers and what makes cancers happen, as I kind of mentioned before, a cancer is an accumulation of a lot of different mutations or different genetic mistakes that can happen within the cells. So if we kind of think about this as a process, we have our kind of first hit, our first mutation that happens within a cell. And then there is a second hit that starts in that same cell, and then a third hit and a fourth hit. And with all of those successive hits, eventually those cells are going to be able to start growing out of control, stop listening to our checkpoints, stop listening to our controlling mechanisms to make sure that it doesn't grow out of control. And eventually those cells have the ability to start growing into a cancer. And so that's kind of what happens within this process. Now, when thinking and kind of going, okay, so when thinking about, again, these genes and cancer, we know everybody gets 2 copies of every gene. You get 1 copy of a gene from your mother, and you get a corresponding copy of the same gene from your father. Now, when we're thinking about genes and cancer, we're talking about a special kind of gene inside of our cell that we call tumor suppressor genes. So we can kind of imagine these tumor suppressor genes making proteins that kind of work like a brake inside of our cell that can help regulate our cells so that they're not growing out of control and prevent them from growing into cancer. Now, most people are born with 2 working copies of their tumor suppressor genes. They get 1 working copy from mom, 1 working copy from dad. And so when most people are born, they're born with these 2 functional breaks at the start of their life. Now, as people eat different foods, drink different drinks, live different places, get exposed to different things in the environment, and again, just that natural wear and tear that happens in our bodies, it's possible that one of those brakes can get damaged and knocked out so that it doesn't work anymore. But that's okay because you have a backup brake. And that backup brake is enough to stop that cell from growing out of control, prevent it from growing into cancer. But over time, as you get exposed to different things and natural wear and tear that's happening, it's possible that that second brake can get damaged. Once you have both of those missing brakes within that cell, now the cell has this possibility where it can start growing out of control and growing into cancer. Now, when you're born with these two working brakes and those get knocked out and lead to cancers developing, those are the sporadic cancers that happen, just the random cancers, the lightning bolt cancers that happen over time. When we think about these individuals, this takes a long time for this process to happen. And that's why when we typically think about most individuals who develop cancer, they tend to develop cancers at later ages. So we tend to see people in their 60s, 70s, 80s with cancers. And those cancers tend to be the more common kinds of cancers. For some reason, there are just certain parts of the body that can grow out of control a little bit easier than others. So if we think about breast cancer in women is a very common cancer, prostate cancer in men is very common, colon cancer, lung cancer, these are all very common cancers that we see, but again, we tend to see it at later ages. And that's why it's recommended that we start our screening. So everybody in the general population is recommended to start their screenings at certain ages and continue them regularly because we never know who's going to get tagged by that lightning bolt. Now, in the hereditary cancers, what happens is that instead of a person being born with these two working brakes at the start of your life, one copy of your gene, and it can either come from your mother or it can come from your father, but one copy has a spelling mistake in it, a recipe change in it, so that it doesn't make a protein that can work as a brake anymore. So that individual is only born with one working brake inside of all of their cells in their body. And then if something happens to that one working brake, there's no backup. And so then the cell can grow into cancer more easily than we would usually expect to see. And so when we think about the hallmarks of or the clues of something that can have a hereditary cancer, one clue is that sometimes we might see these cancers diagnosed at younger ages that we wouldn't always typically expect. So if we see a woman with a breast cancer when she's in her 30s instead of when she's in her 60s, that can sometimes be a clue that maybe it's because of a hereditary cause for that cancer. But that's not the only thing that we look at. We also sometimes want to kind of take a step back and look at the full picture. What types of cancers have people been diagnosed with? Have they been diagnosed with more unusual types of cancers, like a woman with an ovarian cancer, or a man with a breast cancer, or somebody with pancreatic cancer? Those cancers don't happen very often. And so if those unusual cancers pop up within a family, that can sometimes be a clue that maybe there could be some hereditary cause for that. Another clue that we think about is if somebody has a genetic mutation or that hereditary cause for their cancer, that hereditary cause is in every single cell in that person's body. And so sometimes a person might be at a risk to get more than one kind of cancer over his or her lifetime. So for example, there are very well-known genes called the BRCA genes, the BRCA1 and the BRCA2 genes. Everybody carries two BRCA genes. But if one of your genes has a genetic mutation in that, and if you are a woman, you have a high chance to develop a breast cancer over your lifetime. You have a high chance to develop a second breast cancer over your lifetime, and you have a higher chance to develop an ovarian cancer over your lifetime. So if we can identify who falls into that category, your doctors can follow you appropriately, hopefully potentially bump up your screenings, maybe be able to offer you preventive surgeries if that could be the case, to be more proactive about your health. And so that's why some of having this knowledge about this hereditary cancer can be important information. Now, another key of these cancer hallmarks of hereditary cancers is that many times we will also see many generations in a family affected with similar kinds of cancers. It does not have to be the exact same type of cancer, because sometimes these genes have associations with more than one kind of cancer. But when we think about how our genes work, if everybody has 2 copies of a gene, they inherited 1 copy of that gene from their father, and they got the other copy of that gene from their mother, who also has 2 copies of each of their genes, who got their genes from their 2 parents. So all of our genes keep getting passed from generation to generation through the bloodline. If somebody does have a genetic mutation or that misspelling within a gene, that must have come from somewhere. It must have come from somebody's parent who got it from their parent. And so if we looked at a family line, many times we might see a grandparent and aunts and uncles and cousins all having these similar patterns of potential earlier cancers, unusual cancers, and maybe more cancer within a family than we would typically expect to see. And so when somebody has some of these hallmarks of these hereditary forms of cancers, it's possible that they may be offered certain types of genetic testing. Now, there are a lot of different kinds of genetic tests out there, and sometimes it helps to understand some terminology, some genetic terminology that happens, because it can help and understand what kind of testing people have. So when thinking about different kinds of mutations or genetic mutations that can happen in the body, we actually need to separate those mutations into one category, which are called somatic mutations, and a different category that we call germline mutations. Now, in somatic mutations, these are mutations that happen in non-germline tissues, meaning these happen anywhere in the body that's not in an egg or a sperm. Because anywhere else in the body, you do not pass those genetic pieces of material on to the next generation. And so if you develop somatic mutations in the body, those cannot be inherited. They cannot be passed on to the next generation. However, these are what typically causes cancers to develop. Having these somatic mutations in the body and having the buildup of these somatic mutations is what can cause certain forms of cancers to happen. So if I have a buildup of somatic mutations that are happening within my breast tissue, that will allow my breast cells to be able to grow into a breast cancer. And those mutations are those causes of what's going on with my breast cancer. Now, the other kind of mutations that we have are called germline mutations. These are mutations that are present within either an egg or a sperm, and these are the mutations that can get passed from generation to generation. Because if you pass a genetic mutation on through one of these germline cells, like an egg or a sperm, those are the genetic information and the genetic material that are used to help develop the next generation. They develop from all of those cells. And so these are ones that we consider inherited. They can cause family syndromes. They can cause some of these hallmark syndromes that we can look at when thinking about these genetic or inherited forms of cancer. So then that kind of helps us a little bit in terms of understanding what types of genetic tests there are available. Because when somebody has a cancer diagnosis, they may have a lot of different kinds of genetic tests that are offered to them by their oncologist. So there's a category of those genetic tests that we call somatic testing. These are also called tumor tests. Sometimes doctors will call them genomic tests. Sometimes doctors will call them liquid biopsies. Basically, what these tests do is that they want to look at the mutations that you have within your cancer itself to see if there can be any benefit in certain forms of treatment to that cancer. So they can use this for treatment decisions, and sometimes they can use this for prognosis information as well, in terms of if you see certain mutations, you may know it is very amenable to certain types of treatments and responds very well to treatments. Or if it has other mutations, maybe it doesn't respond to those types of treatments as well. So your doctors can tailor what are the best treatments available when they sometimes order somatic testing. Now, not all types of cancers are going to benefit from these somatic tests. We're still learning a lot about these somatic mutations. And so sometimes doctors will offer them to you along your cancer journey. Sometimes they may not offer it to you in your initial cancer journey, but they may offer it to you later in your cancer journey. So it depends on what types of cancers people have, what therapy options there are, and hopefully the oncologists are aware of when they may want to utilize some of these somatic tests. These somatic tests also have a great potential use in our future, where now there is very interesting technology that can help in terms of screening for cancer before somebody actually has a diagnosis or an actual diagnosis of a cancer. So there are new technologies out there. One type of test is called the Gallery test, where you could actually do a blood draw, send it to the laboratory. They can look to see if that blood has any somatic mutations that could be an early sign of a cancer developing. And so then it could lead to a workup and potential looking into, because it's a way that we could potentially diagnose cancers at an earlier stage, hopefully with less invasive procedures, and also hope that we can diagnose some of those more tricky types of cancers that we don't have great screening tools for. So unfortunately, there are cancers that we don't have good screening tools for, but hopefully in the future, these blood tests can look for some of these somatic mutations and be able to diagnose them early. Now, in terms of the germline testing, many times these are the tests that we call the genetic tests. Many times these are also just called BRCA testing. So a lot of times you may have heard of the BRCA testing or the genetic testing. These are the tests that people have to look at their germline tissue. Now, we're not going to test, we don't need to test your egg cells or your sperm cells for the germline test. We just have to test any part in your body, because when you were born, you had your initial genetic information, and that genetic information was copied and made exactly the same in all of your genes, in all of your cells. So a lot of times a genetic test can be taken from your blood. It can be done through a saliva test. It can be done sometimes through what we call a skin biopsy, because we can look at any part of your body for these genetic information, for your germline information, because that's going to be the same genetic material that you have all throughout your body. Now, the implications of this test is to see, one, do you have an underlying cause for a cancer that you may already have? So sometimes it can give you an answer in terms of, why did this happen? Sometimes in those 10% of cancers, we can find that people have these inherited mutations that can explain their own cancer diagnosis. Sometimes it can also be used for treatment decisions. There are certain germline mutations, certain inherited mutations that oncologists can use for treatment decisions. So for example, there's a range of therapies that we call PARP inhibitors. Those are specific drugs that are targeting BRCA-like cancers, primarily breast cancers and ovarian cancers and pancreatic cancers in individuals. And so if somebody has a breast cancer and a specific subset of breast cancer, and if they have a known BRCA mutation, they may also be able to get some of these specific targeted therapies. As I mentioned before, this can sometimes be helpful information for future cancer risk and screening recommendations. So if you've already had a cancer, it can sometimes help us know how to follow you a little bit differently, or if we need to follow you any differently for other risks of cancers. But if you do not have a cancer, and if you have a genetic mutation that's associated with an increased risk for cancer, maybe we can start to put those screening tools in place before you develop a cancer. And we now have a group of individuals that we now call pre-vivors. These are the individuals who have genetic inherited mutations that predispose them to get cancer, but they put different screening and prevention protocols in place to be able to prevent them from getting a cancer in the first place. And these are our pre-vivors that we're now having a fair amount of those individuals that we can follow, and hopefully they may never develop a cancer. Or if they do develop a cancer, hopefully we can catch it at a very early stage. Because we know if we can catch cancer at an early stage, that gives our doctors the best chance that they can help combat those cancers and be able to treat those appropriately. And then the last piece of information about these germline tests is that if somebody does have a germline mutation, this is a family project. This is not something that you yourself carry. It's something that you inherited from your mother or your father. And so if you have siblings, or if you have children, or if you have cousins, or if you have aunts and uncles, there is a possibility that other family members could carry the same inherited predisposition that you may have. And again, they can take that information to their doctors and say, hey, my brother just got tested and he tested positive for this. Can I do testing as well? And so hopefully the doctors can be able to facilitate that process to be able to provide the best and greatest information for family members. So now really quickly, just kind of talking about these different myths that are associated with genetic testing. So the first myth is that if you tested negative for BRCA, you'll never need genetic testing again. So the tricky thing about doing these germline tests is that if we do genetic testing, and let's say we did it 10 years ago, there's a bunch of new discoveries that are happening all of the time. And so there are new genes that are being discovered sometimes that are involved in cancer that we didn't know about 10 years ago. Sometimes our technology is getting better where it can detect different kinds of mutations in the same gene that somebody was already tested for, even though we now have this new type of technology available. So if you look here, this is just kind of the evolution of hereditary breast cancer testing. In 1988, they first started searching for the breast cancer genes, and those were eventually found. The big ones were found in 1994 and in 1995. The BRCA1 and the BRCA2 genes were sequenced. Starting in 1996, we then started getting genetic clinical testing available for the BRCA1 and the BRCA2 genes. And now, all of a sudden, we're starting to learn about new genes that are popping up that can also be associated with breast cancer. There's a gene called the TP53 gene, a gene called the P10 gene, a gene called the CHEK2 gene, all of these different genes, but we didn't really test for those very regularly until about 2013. We then started to develop, or actually it says 2012. And 2012, we started to develop these multi-gene panels where we can look at a lot of different genes at the same time. So instead of just doing BRCA1 and BRCA2 testing, now we can look at a large number of different genes at the same time. And again, there are different ways that we would have looked at the genes currently that we didn't necessarily have in the past. So now we have the technology to look at your DNA, which is that main molecule that we have for our genetic information, but we've also added a second component to genetic testing sometimes that looks at a different molecule called RNA. And that is important information in terms of the instructions for making that protein. So we're learning more year by year, and our technology is really blossoming year to year. So what I would say is, let's say you had BRCA testing done in the past, a good cutoff is kind of like 2013. If you had BRCA testing, or maybe even 2015, because not all doctors work all up to date in terms of genetic testing, but if you had BRCA testing before 2015, might be a good idea to re-examine that BRCA testing, see if there are other genes that you may need to get tested for, or maybe offered to get testing for. And this is just a list from one of the laboratories and a lot of the different types of tumors that we can currently test for and the genes that we currently test for. So if we look here, there's about 40 different genes that are listed that we now know of. There's actually 70, 80, 90 different genes that people can now do genetic testing for. But if we look, they're associated with lots of different kinds of cancers. So there are some genes that are associated with breast and gyne cancers, some genes that are associated with your endocrine system, some genes that are associated with your gastrointestinal system or your renal system. There are not as many genes out there for hematologic malignancies. Those are the leukemias and the lymphomas. These genes have newer technology that we can sometimes do genetic testing for, but a lot of lymphomas are actually considered many times in that non-hereditary category. Leukemias, we are learning that there are some hereditary forms of leukemias that we can test for, but we don't have that wealth of knowledge just yet. We're getting there, but it's a little bit more of a complicated system and testing system. But again, we test for a lot of different genes, and each of these different genes can have their own subset of cancers that are associated with it. So hypothetically, if somebody undergoes genetic testing and they test positive for one of these genes that we call the ATM gene, that lets us know, okay, well, that can be associated with an increased risk for breast cancer. That can be associated with an increased risk for prostate cancer. That can be associated with an increased risk for pancreatic cancer. So let's make sure we're following people appropriately based on that genetic profile that we can identify in an individual. So again, this kind of talks a little bit more about what I already mentioned, which is if you've already had testing, but you had it done before 2014, you may qualify for update genetic panel testing. And so you can contact your healthcare professional. Usually I say kind of give it every 5 to 10 years. So if you've had genetic testing done within the past 5 or 10 years, you probably might not need update genetic testing, but that would be a good number to circle back to your healthcare provider and see if you may be a candidate for updated genetic testing. It's always also very helpful to inform your provider of any new diagnoses of cancer in your family. Because let's say someone comes in and they have a family history of breast cancer, it's possible you might only be looking at the breast cancer genes, but then all of a sudden somebody in a family, someone in the same family is diagnosed with a colon cancer. Well, we didn't look at the genes related to colon cancer, so now we need to go back and re-examine some of those other genes that we may not have looked at. So it's always very beneficial to update your doctors and other providers about any changes within cancers within your family. And another helpful piece of information is that there are different and new updated screening recommendations regarding previously known genes. So I'm going to use BRCA again as an example, and it doesn't apply to everybody. It's just these genes that a lot of people are aware of. So I sometimes use these genes as examples. But in the past, in the 1990s, when we first identified people with these BRCA mutations, we only screened women for breast cancer and ovarian cancer. Those were the two cancers that we followed people for. But now recent discoveries have shown that we should really start monitoring men for prostate cancer risk, and we should also start monitoring everybody for pancreatic cancer risk. So our recommendations in terms of how we follow individuals has changed over time because we're learning more and more things about these families. And so again, these are always helpful pieces of information that you might want to ask your providers, your healthcare providers about. And sometimes how a laboratory interprets your genetic test can also change over time. So as the laboratories are getting better with their technology, something that they may have thought was negative in the past can sometimes get updated to a positive mutation now. And so sometimes what they thought wasn't a harmful variation within a gene, they may now learn is associated with an increased risk for cancers. And so on very rare occasions, people might get contacted by their healthcare providers to say that there's been a change in how those tests have been interpreted. And so if it does change how you are offered your medical management, hopefully your doctor can update you with that information. Another myth of genetic testing is that the genetic test will cost thousands of dollars. That used to be the case, but luckily it doesn't involve typically thousands of dollars anymore. So the one important piece of information is that insurance companies have broadened their coverage for genetic testing. In the past, they used to be very particular about who they would cover for genetic testing because it was an incredibly expensive test, and they wanted to make sure that their insurance dollars were being utilized appropriately. Now, the cost of the test is actually not that as high as it used to be. And so they are offering these tests more and more to a broader group of individuals. So in the past, if you were diagnosed with breast cancer under the age of 45 or 45 and under, you would be offered genetic testing without any family history. But now they offer it to any woman who's diagnosed at 50 years or younger. So the age at which we're starting to test people is starting to become a little bit more broad. In the past, if you had a specific kind of a breast cancer called triple negative breast cancer, we used to only offer genetic testing if you had triple negative breast cancer that was diagnosed under the age of 60. But now we're offering it to anybody, any age, who's diagnosed with triple negative breast cancer. And some insurance companies will now cover genetic testing for lots of different kinds of cancers, even if you don't necessarily meet the national testing guidelines, some insurance companies have even broader coverages. So just because you may not have had coverage in the past, it doesn't mean that you may not have coverage now. And also, there's a lot more competition nowadays in terms of the cost of the genetic testing and what they bill to insurances and what they bill to patients. So previously to 2013, there was one genetic laboratory who held the patent for the BRCA genes. And these were the only, this was the only laboratory in the United States that was allowed to offer clinical testing with the BRCA1 and the BRCA2. But there was a Supreme Court ruling in 2013 that said that they could not patent human genes and that they were not allowed to be the only ones to offer this. And so then there was a blossoming of a lot of other laboratories that were able to start offering genetic testing for BRCA genes as well as other genes. And so now there are, because there's a competition in the market, it's really driven the prices down for the genetic testing. However, it's also important to remember that not all genetic laboratories are created equal. Some genetic laboratories are better than others, especially when we think about direct-to-consumer testing, which are like the 23andMe type tests that you can do just to send it out through the mail without ordering through a provider like a physician or a genetic counselor. The direct-to-consumer testing is not as in-depth or high definition as a test that will be ordered by a doctor or a genetic counselor or a different genetic provider, healthcare provider. So just remember that just because you may have had negative 23andMe testing for your BRCA, it doesn't actually mean that you had that full analysis of your BRCA genes. And so you may want to talk to your healthcare providers, doctors, genetic counselors to see what type of testing did you have in the past. Is it worthwhile to do updated genetic testing now? All right, myth number 3, men don't need to get genetic testing. In the past, there used to be an idea that these genetic mutations would only be passed through a maternal line. They could only be passed on from a mother to a daughter. Now we know that's not the case. Everybody has 2 copies of their genes. Men have 2 copies of their genes. Women have 2 copies of their genes. Anytime you have a child, it's a flip of the coin chance which gene gets passed on to the next generation. So even if there's cancer in a paternal father's line, that can still be helpful information to know about your family history and know about any increased risks for cancers. And also, we also know that some of these genes, as I had mentioned previously, we're starting to screen men for some of these cancers, where in the past we would only screen women for cancers. So again, examples are the BRCA1 and BRCA2, but there's a different gene out there called Lynch syndrome. Lynch syndrome is primarily associated with colon cancer, prostate cancers, pancreatic cancers, uterine cancers. And so just because someone may not have a BRCA mutation, if they have a Lynch syndrome mutation, we want to make sure that we're following the people within that family appropriately. Myth number 4, you have to have a genetic mutation to be considered as having a high lifetime risk for cancer. Just because someone does not carry a genetic mutation, it does not mean that you may not have or qualify for being followed as a higher risk individual based on your family history. So family history is a very helpful piece of information that doctors can benefit from. So when they ask you questions about your family history, that can really help them assess if you may need to get extra screenings for certain forms of cancers. For example, if a man has a father and a brother and a grandfather with prostate cancer, even though he doesn't have a genetic mutation, we want to make sure that we're following that man appropriately in terms of his prostate cancer risk, because we see it affecting his family members. If a woman has a mom and a sister and a grandmother with breast cancer, even if she doesn't have a BRCA mutation, or even if she doesn't have another mutation, we don't want to ignore the fact that she still has a family history of breast cancer. And so we want to make sure that we're following those individuals appropriately. Sometimes if a woman has a higher chance of developing a breast cancer, they may be offered an extra screening tool on top of their mammogram that we call a breast MRI. Sometimes there are medications that we could offer people. Sometimes we might need to offer individuals more frequent colonoscopies or more frequent PSA blood draws or digital rectal exams. There are lots of different things that doctors can do based on your family history. So sometimes, regardless of genetic testing, your family history should also be a guide in terms of how your doctors will follow you. Oh, and I guess that's it. So those were all of the things that I had to say. So I don't know if Rebecca wants to ask questions from the pool here.
Thank you so much, Karen. We'll start with some online questions and then we'll move to in-person. So for those online, if you do have a question, feel free to put them into the chat. So the first one is, if one has triple negative breast cancer, is the genetic testing for only that, or does it cover the whole multicolored grid that was on your slide?
That's a great question. So it actually depends on who might be ordering the test and what type of test that they may offer you. So my recommendation is that if somebody has a cancer diagnosis right now that they're being followed for, if you are being followed by a medical oncologist and you're interested in doing genetic testing, you may want to ask your oncologist, one, either to refer you to a genetic specialist, or sometimes if they are not able to refer you to a genetic specialist just due to insurance or other reasons, they may order the genetic testing themselves. Now, when I see a patient in clinic, what I usually do is ask very detailed questions about a person's cancer diagnosis or diagnoses. I ask very detailed questions about different family members. So it helps to understand a full family in terms of how old were people when they passed away? How many people in a family were diagnosed with cancers? What ages were they diagnosed with cancers? What types of cancers were they diagnosed with? And based on that interpretation, many times it helps me to understand and know which is the most appropriate genetic test to offer a patient. So a lot of times it's not a one-size-fits-all category. We sometimes want to interpret somebody's family history and personal history before moving forward with the genetic testing. And so that's why it can sometimes be helpful to meet with a genetics professional first. Again, I understand that not everybody has the ability to meet with a genetics professional. And so sometimes a doctor or oncologist may order the genetic testing themselves. If they do, a lot of times most physicians will order this broader panel, but it's a very physician and provider dependent. Not everybody orders the same test. So it's really dependent on who you see and what signs your family has to make sure that they're looking at the appropriate genes. If it is something that you are interested in kind of broadening that search, broadening that category, you can have a discussion with your provider about looking at a lot of different genes. When I see individuals in clinic, I do not always, bigger is not always better. Sometimes when we look at these really broad genetic tests and look at 100 different genes, sometimes we can get a lot of gray answers back that are not always very helpful and can sometimes increase an individual's anxiety about different things that they may not need to have any anxiety about. So sometimes when we think about genetic testing, kind of going back to that recipe analogy, and I realize I forgot to do this even though it was in my brain. So going back to that recipe analogy, if I am looking at my chocolate chip cookie recipe and I'm comparing it to my recipe book, hopefully I copied it down exactly the way that it's written in my recipe book. And if I'm looking at my recipe and comparing it to my recipe book, and if it looks exactly the same, then I'm going to put it in the negative mutation bucket because that doesn't look like there's any mutation there. Everything's looking as it was written in the recipe book. So it's all looking okay. I'm going to put it in that negative bucket. Now, let's say I'm looking at somebody else's cookie recipe and I see that they've completely forgotten to write down the sugar in their cookie recipe. I'm looking at that, I'm comparing it to my main recipe book, and common sense is going to tell me having a cookie without sugar is not going to be the right kind of cookie recipe. So I'm going to put that in the positive mutation bucket because I know that that's not going to make a good chocolate chip cookie. Now, let's say I'm looking at somebody's third recipe and I see that by accident, this individual wrote down a half a cup of sugar instead of 1 cup of sugar. Now, I see that it still has sugar. It's a little bit less than typical, but I don't actually know if that cookie recipe is going to create a good chocolate chip cookie. Is that going to be a tasty chocolate chip cookie? Or is that going to not be a tasty chocolate chip cookie? I have absolutely no idea. So I can't put it in the positive bucket. I can't put it in the negative bucket. So scientists have then created a middle bucket that we call variants of uncertain significance. We call these VUS for short. And basically, when somebody has this, they have these unique variations in their own genes, but the scientists do not have enough data. They do not have enough knowledge which bucket to put it in. They don't want to put it in the positive bucket because they're not 100% sure that it's positive. They also don't want to put it in the negative bucket because they're not 100% sure that it's negative. So you have this variant of uncertain significant category that's a little bit more gray. Now, the greater the number of genes that we test for, even if we're looking at genes that are not related to cancers within your family, there is the greater likelihood that some of these variations are going to pop up in your genetic testing. And so you may come back with a variant of uncertain significance in a gene that's completely unrelated to your family history. So hopefully your providers and your genetic professionals can, again, make sure that they're honing in on the right kind of genes. Bigger isn't always better, but sometimes bigger can be helpful. So that's where the interpretation of your personal and your family history can play in.
Wonderful. Thank you so much for that analogy as well. There was a question in the chat to you specifically. If you don't mind reading this and then just summarizing for everyone here. Okay.
All right.
Yeah.
Okay.
One moment.
So
And then
go ahead.
if you want to just read it and summarize it.
Perfect. Okay. So read it silently.
Yeah, read it silently,
Okay.
yeah.
All right. Give me a minute.
And then we'll get to the in-person questions. And then for those online, if you have a question, please feel free to put it into the chat, or you can unmute yourself and that'll indicate to me that you have a question and I can call on you. So Karen is reading a question, but has, I think, a little bit of more
Hold on.
personal information. So she's just reading it and going to give us the bits that we need to know.
Oops. For some reason, I'm not able to scroll the question very well. I think,
We know it's the end of it.
okay. So there is an individual who's asking questions about they tested positive for Lynch syndrome, but then they got updated genetic testing and tested positive for another genetic mutation on top of that. Sometimes we do see individuals can have more than one genetic predisposition within a family, so it definitely happens. This individual has different cancers within her family. She also has other kinds of diseases within her family, such as dementia and kidney disease. That individual wants to know how diligently should they be followed? How diligently should they be taken care of? So, every individual is unique. Every individual has their own genetic profile and also has their own family history and their own personal history and their own exposures. So it's difficult to know what the most appropriate screening is for an individual. And my advice is to meet with a specialist in those different fields. So if you have a genetic predisposition for certain forms of cancer, it can be very helpful to meet with a genetic counselor or a different genetic professional and go over the current guidelines and the current screening recommendations that are available now. If you have family histories of dementia or family histories of kidney disease or other things, it can be helpful to meet with a neurologist or help to meet with a kidney specialist to go into, should I be doing extra screening based on my family history? What is the appropriate screening? So sometimes it can help to meet with that specialist because everybody has this unique genetic profile. But again, I would say meet with that that person who's specific to that field, and they can hopefully answer some of those questions.
Thank you, Karen. So for those in person, are there any questions? Okay, let's go on.
First of all, I want to thank you, Karen, for such a clear presentation.
Oh, thank you.
On this very complicated subject. My question is that family history, I find that oftentimes that's not being updated. I mean, initially you have all these papers fill out, But throughout the year, let's say a couple of years ago, my family had a diagnosis of the same kind as mine. I don't think that's on the paper.
Right. Yes, that's a very, and I don't know if everybody on Zoom can hear it. Okay, perfect. That's a great question. Not all providers will re-ask you questions about your family history, even though it can be important. So be a squeaky wheel. If something happened in your family and you have an appointment with your doctor, tell your doctor or your provider, say, oh, you know what? My sister was just recently diagnosed with the same cancer that I had, or my brother was just diagnosed with pancreatic cancer. Make sure your doctors know that, even though they are not the ones asking the questions. So definitely be a squeaky wheel on that one, because doctors many times will forget they've got a lot of things to do in a very short amount of time. And so they're limited in terms of their questions that they can ask.
Excellent presentation. Thank you. I'm interested in that Gallery blood test. I had breast cancer, as did my other two sisters, exact same kind of breast cancer and the exact same breast. I'm now having some pain and discharge and cannot get in for more screening until April. Is that something that would be appropriate for me, or is that available yet?
That's a great question. Oh,
For the printed out.
sure. There is an individual here that's asking about the Gallery blood test in terms of a screening type of a test that can be used for cancer. These are up and coming tests. They are not currently FDA approved tests. There are a lot of hospital systems, including ours, that are offering clinical trials for the Gallery tests or similar like Gallery tests. So a lot of times you may be eligible in a clinical trial for that. Sometimes you can ask your physician for that test, but it does have a hefty price tag right now because it is not approved by FDA and therefore not covered by insurance. And because it's not approved by FDA, the data is not all there yet. They're still gathering a lot of that data. So just because somebody has a negative screening Gallery test, we don't want them to think that they may not have a cancer. We would definitely encourage you to continue with your appropriate follow-up in terms of your screenings and imaging that you might be recommended to have. And just because somebody has a positive Gallery test, meaning that they may have a cancer, it doesn't necessarily mean that they do have a cancer. So it's not a perfect tool that we have currently. The data is still coming. But you can always ask. I know at Memorial, we are offering a current clinical trial of individuals who are Medicare age for these individuals for Gallery tests. And again, this could be a good screening tool, but it's not a diagnostic tool necessarily. So if you're having symptoms, we definitely want you to get the appropriate imaging and the appropriate workup for that.
Karen?
Study?
So someone was asking if it was the Pathfinder study. Yes, the Pathfinder study was the previous study that we had, and a lot of other locations had something called the Pathfinder study, where they offered it to people who were 50 and over without a personal history of cancer within the past 3 years. I think that was the main criteria. Now, the Pathfinder study has closed, but there is a new study that just opened, and Dr. Stipic emailed me yesterday, and I cannot remember what it was called. Do you remember? Do you know what it's called? The new study? Okay.
Karen, I'm in the audience online. Are you able to hear me?
I can hear you. Yes.
I may be able to add a piece of information. As it happens, I called Gallery yesterday and I asked if I would be eligible for a Gallery test. It's over a year since triple negative was removed, and I recently got a melanoma diagnosis, and I was wanting to know how long after the melanoma is removed can I reasonably take the Gallery test and expect it to be accurate? And she said they discourage anyone who is less than 3 years NED, no evidence of disease, or less than 3 years into remission from taking it because Pathfinder and their other qualifying tests only involved people who were more than 3 years away from cancer treatment.
Thank you so much for that information, Linda. Yes, they do not, they discourage people from taking these blood screening tests if you've had an active cancer within the past 3 years. So you should be 3 years out, being no evidence of disease for the Gallery test or for other similar type tests. And again, this is only a screening test. It is not a diagnostic test. So it's always helpful to know the difference. If you're having clinical symptoms, definitely make sure that you can take that to your doctor. And unfortunately, you know, sometimes hospitals or other imaging centers are impacted, but may not hurt to kind of keep calling and see if they have an open appointment. Maybe you can get in before that appointment date.
All right, thank you. Go ahead.
Hi, you do the RGCC.
I'm sorry, can you repeat that? And also, I don't know what that is, so maybe if you can elaborate a little bit. Oh.
RGCC.
Okay,
And you usually send it out to Greece because they don't do it.
okay.
So
Yes,
that's what I've been doing. My test is, what it does is it tests the circulating tumor cells.
thank you so much for clarifying that. So a lot of times tests like liquid biopsies or those other somatic tests like tumor profiling tests are almost always ordered by your medical oncologist, not by a genetic counselor. Genetic counselors primarily only deal with the germline testing, the inherited types of testing. But if it's anything that is associated with treatment decisions or clinical or circulating tumor cells in terms of your own cancer diagnosis and how it's responding to therapies, or if you may need to change your therapies, those are predominantly ordered just by the medical oncologist or your other physicians who are involved in your cancer care. So unfortunately, I wouldn't order a test similar to that. Those I leave up to the medical oncologists at our hospital system.
Yes, my 3 aunties were diagnosed with stomach cancer, and I've been diagnosed with breast cancer. So it seems that it's running in my family, genetics that you mentioned. But now my question is, what kind of steps do I need by my oncologist order a test that if I have that also in my stomach? Or what can I do? Or what kind of test I should ask?
That's a very good question. So this individual has mentioned, asked if I test positive for something and it shows that I have a type of a risk of developing a stomach cancer or a colon cancer, what can I do with that information? So a lot of times what a doctor or genetic counselor will do is look at your family history, look at your genetic information, kind of take it all as a whole and determine what is your overall chance to get these specific types of cancers? Is it a lot higher than somebody's chance in the general population, or is it just a bump up higher than somebody in the general population? And that can be information that can be used to help make some screening recommendations in terms of, you know, are you a good candidate to do an upper endoscopy? And how regularly should you do an upper endoscopy to screen for these? Sometimes if somebody has an increased risk of developing a pancreatic cancer, people are like, well, what can I do about that? I can't remove my pancreas. This is a very important organ. And that's true. We want you to keep your pancreas intact. It is a really important part of your body. But we can add on extra screenings. There are tests that we call upper endoscopic ultrasounds that we can offer. There's special kinds of MRIs called MRCPs that people may offer you. So the hope is that if we do identify that you are at an increased risk, maybe we can offer you these certain tools at reasonable intervals to be able to screen you appropriately. The tricky thing is we don't want to under-screen you. We also don't want to over-screen you. We want to try and find the appropriate screening based on your own history. And everybody's recommendations vary depending on their personal history, their family history, as well as their genetic test results.
I've gotten cancer from hernia mesh. And so I have it removed, I got it removed holistically. So I have another hernia on the other side. And so now I want to, is there a way to test for different types of mesh? Because it's my own blood.
That's a very good question. So somebody was asking about their previous medical history. They was potentially a cause for their cancer history. I would say ask a doctor about that, or you can look more in detail in that specific type of treatment or technology. Unfortunately, I am not aware of different techniques and different meshes or different things like that. These are great questions for your doctor.
They show what kind of cancer in your body?
I'm sorry, can you repeat that?
That blood tests show all kind of cancer in your body?
Well, it depends. So the question is, does a blood test reveal all kinds of cancers in your body? So when thinking about these two types of tests, if we're thinking about the germline kind of a test, like a blood test or a saliva test or a swab test, those don't actually tell us if somebody has a cancer right now. All it can tell us is, was somebody born with a higher chance to get a cancer? It doesn't mean they are going to get a cancer. It just means that they may have a higher chance to get those cancers. And so again, it can be guidance for your doctors to make sure that you're screening properly. Some of these other blood tests, like a liquid biopsy or like that Gallery test, are sometimes used to see cancer in your body, but they're very specific to the type of cancer that you may already have, or specific to screening for potential other cancers. And again, it doesn't mean that you may have a cancer. It just is different technology that the doctors can use to follow you appropriately.
Thank you. Last question? Did you? No? Okay.
You know, since I told you that my other two sisters have the same exact cancer and a paternal cousin also, do the 27 genes that they tested were negative, that group of 27 genes, do you assume it's environmental, or that we just didn't test the right gene? And where do you go from here?
That's a great question. And unfortunately, we're limited in terms of kind of clinical trials that are available when we see families that look like there might be some kind of genetic mutation, and we can't find those genetic mutations just yet. You know, we don't know. It's possible it could be environmental. It could be smaller genetic components. It's possible it could be a mutation that we just don't currently have the technology to detect. So my best advice is just circle back every 5 years, 5 to 10 years, circle back and see if there's kind of these bigger new updated tests. Unfortunately, many families kind of fall into that question mark category, and we don't have all the answers just yet. Yeah.
My final last question.
All righty.
So there's a question: if we wanted to set up an appointment with Karen, how do we do it?
Great question. So if you wanted to set up an appointment, my telephone number is on the screen. That's my direct telephone number. There's also my email that is on the screen. Feel free to email me directly, call me directly, and I can kind of walk you through that process. At Long Beach Memorial, we have genetic counselors, but we don't have an overseeing physician. So we are not trained physicians. We are trained genetic counselors. And so therefore, we do need orders or referrals from a provider, from an actual physician. And we have a lot of insurance ins and outs. So everybody has their own kind of insurance. It can sometimes be a little bit tricky. So contact me directly and I can walk you through it.
Wonderful. Well, thank you so much, Karen.
Thanks,
for this
Rebecca.
informative workshop. We really appreciate it.
Thank you very much. It was a pleasure.